nutrition, it was not enteral nutrition, it was all by mouth. The reason I say that's sad is that 5 of those 186 patients came in with a feeding tube in place, and nobody was using them. And I said, why aren't you using this? You've lost all this weight. Well, they put it in during my surgery, but nobody ever told me how to use it. So that's one of the things when I do a physical exam, I always make sure they don't have a feeding tube in, and if they do, then one can use it. What's interesting is of those 186 patients, 50% of them stopped losing weight and improved their visceral protein status. Look, I like transparent. But of the people who had at least a 6-week life expectancy, 80% of them stopped their weight loss, which is the first step to gaining weight, and also improved their visceral protein status. So this is the gold standard that is non-high-tech, that is not expensive, that's doing the things that we all need to do and are currently doing with our patients, but doing it in a standardized way. So this was the version in 1995, still not scored, but starting to look a little bit more like box 1, 2, 3, and 4 of the PG-SGA, and the professional component were down here at the bottom. If you look at this, again, now you're starting to see the PG-SGA that a lot of us know. This was when it was all on one page, and you'll also see some scoring if you could. There's little numbers at the bottom here. It was the same thing here. And the reality is we had nurses who said, Faith, my eyes are getting too old. I can't read this. The patients can't read this. And in addition, sometimes the patients, even though we say that the therapist or nurse or physician will fill this out, they start filling this out incorrectly. So what we've done at our hospital is we've taken it and put this as kind of a big print version, so all of the patients are on the first page, and all of the clinician component, the professional components on the back. And they asked my permission. I said, no, I think that's a great idea. So that was when we had, in 2005, the first big print version. And I think that, combined with the scoring, is what really made this take off. And I said I had worked with 2 dietitians. One was Suzanne and one was Susan, so they became known as the Sues. We'd all work at our work during the day. We were at all different hospitals. But once a week we'd get together at my house, at my apartment. We'd all sit on the floor and we'd do all of our work together. So when the front desk at my apartment would say, the Sues are here, we'd work. And the reason I always bring them up is, although I get the credit, I have the copyright because they wanted the doctor to have it, they thought that it was important for it to be in one person. The PG-SGA would not exist as it is right now without those 2 dietitians. And part of the reason I say that is Suzanne Kasanek basically for about a year argued with me. And she'd say, Faith, this has to be scored. I said, yes, but it's so important. I want people to think about it and learn it. No, it's got to be scored, which generally is my approach. Make it simple. Don't have to make people think about it. Just do it automatically. For some reason, I was stupid about this. Okay? The reality is we went back and forth. Faith, it has to be scored. No, think, scored, think, scored, think. Finally, Suzanne said, Faith, it has to be scored. I'm going to score it. You're going to completely disagree with how I scored it. You're going to correct me. You're going to do it the way you want it, and then I have what I want. And that's a scored PG-SGA. And she's exactly right. And that's exactly what happened. And that's what's made this work. So occasionally, if you happen to run into a strong-headed physician who you disagree with, or you sometimes have to be subtle in terms of how you do this until you have that really good relationship. The reality is, if you think you know something, and the doctor thinks they know something, and you know better because this is your area of expertise, push it. And eventually it can make a big difference like this. Who would have known 20 years later I'd be sitting in Porto having a discussion about a Portuguese version with the supportive PG-SGA website, all because Suzanne and Susan pushed me. So it really does make a difference. So basically, over the past 2 years, past 20 years, we really are on an anniversary of the Scored PG-SGA. In the last 2 years, I've been working with Hansa University and Harriet Yeager, who you will meet soon. She's the blonde up here. Basically, she was the first one who actually did a Dutch version, translation, back translation, cross-cultural adaptation, validation, etc. And what's interesting is over the last 20 years, at least every month I would have 10 or 20 people reach out to me for information to use it, permission to use it, etc. And she and I had exchanged a few emails, and then on Thanksgiving, which no one celebrates anywhere but in the United States, I went up to visit my father, and she said, "Can we talk?" So Thanksgiving Day, I'm at my father's place. We talked for an hour and a half, nonstop. And I knew this is a woman who I wanted to work with because she did her research right. She was as passionate about her patients, as passionate about this. Now, we're much smarter now. We have weekly Skypes. It doesn't cost us the amount of money that an hour and a half phone call does on a holiday. But now you see the app, and we have the Portuguese version. We've come a long way. That's only in 2 years. We also have, and you're going to hear some really exciting work from Harriet in terms of the number of cities and countries where we've had people visiting our website, including very prominent presence of Portugal and Porto. I don't know why that would be. But the reality is, it's really, we have multiple languages that will soon be following the Portuguese flag on our website. And she'll talk to you a bit about that. There's a group called Know It, which was the Society for Nutritional Oncology Adjuvant Therapy. That was that nonprofit research and education group that I talked about. And there's the Suzanne and Susan that I mentioned. And we actually had a Know It, which was like, I know it's important, we know it's important. But basically we put together a volunteer research network based on people who I've met over the years. Now, I've done a lot of talking, hundreds of different places over the years, and invariably people would come up, "Oh, Faith, the stuff you're talking about is so interesting, so exciting. Here's my business card. If there's ever anything I can do to help you, give me a call." Well, I kept all those cards. And at the point when we decided to do a validation of the scoring that we'd come up with, I took all of those cards and contacted all of those people, and they were the research network that we set up. Now, the aims of that, and it's 9601 because it was the first study we did in 1996, was to perform a feasibility study of the Scored PG-SGA, to validate the scoring and the triage that was based on that. We had some differences over the period of time based on that pilot data, and also to have an understanding of the patient population that we looked at. Basically, we did the protocol development, we did the clinician. Now, I use the term clinician, and that, I guess, it's an American definition. For me, clinician is any healthcare provider. So that includes nurses, physicians, dietitians, therapists, etc. Clinician is not just a doctor, which in some countries is the case. So when I say clinician, think professional. We developed a protocol package, an ethics committee package. Many of the nurses and dietitians who made up 92% of the investigators in this study had never gone before an ethics committee. We gave them the package. So not only did we have the impact on this study, these were people who I think had much more confidence going forward doing this for other studies in the future. They were either inpatient or outpatient setting. We included all diagnoses. These were not limited originally to only cancer patients. They had to be adults at least 18 years of age. They had initially to read and or understand English and Spanish. We subsequently added French when a hospital in Montreal joined us. They could be new or ongoing patients, and we only wanted one evaluation. If they had two, they had to be at least a month in between. Now, again, remember I showed you those point scores of 0 to 5, 5 being death? Well, we decided if that's what oncologists are used to, let's use the same scoring. Remember, I'm a surgeon. I like simple things. I like things I can remember. Most busy oncologists like things that they're used to doing. So we ended up using the same scoring. So 0 points for anything that we scored on the PG-SGA was minimal impact on nutritional risk or deficit. Again, thinking back to that table I showed you before, 4 points are potentially life-threatening, and 1, 2, and 3, again in the same way, are mild, moderate, and severe. So a very easy way of remembering it. This was the original triage that we did, 0 to 1, a score of 2, 3 to 8, or greater than or equal to 9. We found when we asked people afterwards, the one area that they most disagreed with was the 3 to 8 points. And we subsequently changed that based on that initial input to 4 to 8. What was interesting is a lot of people said, well, Faith, if you do it 3 points, every patient I see is going to have to be seen by me in the clinic. I said, for your institution, use whatever cutoff point you think. If you think you only have enough dietitians or nutritionists to be able to see people who are above a score of 7 or 17, I don't care what you use in your institution. It's just a way of doing it. What's interesting is once people did that, they came back to me lots of times and said, you know, you're right, it doesn't make a difference. Once they get to a threshold above 9, there's lots of times 14, 15, 16, 17. So it is that threshold of 9 that's the most important. So, based on that volunteer network of me calling people up when I had their business card, we actually, over a little over a 6-week period of time, totally over 6 months, but most of them in the first 6 weeks, put on with valuable patients of 2,150 patients, a total of 55 institutions. Nobody got paid to do this. It was truly a labor of love. And most of what we're doing subsequently, the translations, the cross-cultural validation, those are labors of love. This really shows how important patients are to people who are in this field. It kind of followed the 80-20 rule. About 80% were outpatient, almost 20% were inpatient. The difference between male and female was about evenly split. We had age groups that ranged anywhere from early 20s to a person who was in their 90s. So broad spectrum. We know that about 3/4 of them were in their 50s to 70s, again, which is probably where most of your patients fall, and 93% of them were in their 40s to 80s. There's a broad spectrum of patients in terms of the demographics. The 2 most common cancers were breast and lung. Again, remember we said there's a difference between these two. Women with breast cancer, most of them, who are especially in early diagnosis, have a 50-50 chance of gaining sometimes very significant amounts of weight. Lung cancer patients lots of times go the other direction. So we had people that went that full spectrum. We also found that we had almost 300 patients with renal disease, 128 of them with end-stage renal disease on dialysis. And it's interesting, I think the original SGA is more often thought of in that setting, but we actually included them as part of our study. We also had about 300 hospice patients. Some of those were HIV, some of them were cancer, some of them were other disease states. So we really have gone the full spectrum of outpatient, inpatient, hospice to early diagnosis. We looked at body mass index, and certainly some really brilliant work has come out of Canada with Ziki Barikos and Martin in terms of looking at the impact of changes in weight and body mass index. But what was interesting, and certainly in the United States, and it's becoming more and more common in other countries also, the number of people who are obese, and BMI really doesn't tell you necessarily. So it's the change in the BMI, the change in the weight, not necessarily what their BMI was. Because if you see here, almost half of the people basically were overweight or obese, despite the fact that they had a cancer diagnosis, despite the fact that we had hospice patients in there, so that we can significantly underestimate. So this is the evolution to where we are right now. This is what's known as, a lot of people use just the first 4 boxes, and this was originally part of the original PG-SGA. It's what's also known as the short form. Some people call it the abbreviated or abridged form. From my perspective, that makes it always sound like it's something different, or that it doesn't have as much. The reality is the short form was inherently always part of this. And now I'm going to tell you a secret about the short form. We'll talk later about the sneaky physical exam. I'm known for sneaky physical exams. But this was also sneaky. If I know that in the majority of centers, everyone's probably not going to do the professional component, and I'm going to do a scoring that's going to help triage who needs intervention, 90%, 80 to 90% of the score for every PG-SGA is based on the score of the short form. And the patient fills this out. It was designed, now there are going to be times when someone can't read, or they're too ill, or they forgot their glasses, or sometimes you're going to have to, as a dietitian or a nutritionist or a surgeon, have to ask the questions. But the reality is it's meant to be done by the patient. Who's going to know better what they're actually feeling? The reality is one of my long-term goals was always to have multiple language versions. What's interesting is my example I used to use. Now you're a gentleman back there. You are not Korean, but I'm going to use you as an example. If you're an 80-year-old Korean man, and when I first started out this, I was a much younger woman, and you walk into my clinic, and even if I know the term in Korean for diarrhea, as an 80-year-old man, you're probably not going to tell me you have it. There's a cultural difference, there's an age difference, there's a gender difference. It's not something you would necessarily communicate. So by having it as a check-off list in someone's individual language, I'm going to get much better, much more honest components. The other reason people say, well, why can't the family member just do it? Well, there are a lot of things that I may not tell my family. I may not tell them about all the crampy abdominal pain I'm having. I may not tell them about the diarrhea or the constipation or the dry mouth. So the reality is that may be a good surrogate, and sometimes you have a family member who will say, oh, that's not true, he does such and such. Well, the bottom line is, I think having both of them is helpful, but if you have to decide who's right, is it going to be the patient or the carer, the caregiver? Should always be the patient. The reality is, you have to give them a sense of pride. Don't take away the control. If the wife says, oh, he has this or he has that, and I'll say, you know, it's interesting. My dad was kind of somebody who would downplay things. You know, he's a guy, he sometimes does that. Now your wife over here is telling me it's a little worse than it is. Is she telling me the truth or should I believe you? Yeah, well, maybe she's right. What it does is it opens the communication, but it gets down to who's right. It's going to always be the patient. And I think that's an important thing. In addition, those nutrition impact symptoms, and that term never existed before the PG-SGA. Because a lot of times people don't think of those as nutrition impact, but they really are things that can make a difference. Sometimes patients don't bring it up because they don't want their doctor to think that they're a complainer or their nurse to think they're a complainer. They don't bring it up because, oh, maybe that means my cancer comes back, so I'm just going to keep it from them and they're going to. By doing it this way, two things happen. It gives them the control, it gives them the awareness, it gives them the empowerment. And the other thing is all of the work, 80 to 90% of the work is done by the patient, not you, which is nice if we can hand all of our work off to the patient. But in addition, where I came from, we'd actually hand it out to the people when they came into the clinic. They'd fill it out, and by the time they got into the clinic room, the exam room, I had all the information they needed to tell me. And my time talking to them was not saying, and do you have constipation?